Hey guys, my name is Mavi and I've spent the last 14 years in the plastic surgery and beauty industry, working alongside top board certified plastic surgeons. In that time, I've helped thousands of women in their surgical journey. My passion to educate and help women feel empowered is what led to what we now know as the Big Butts, No Lies podcast. Join in on the fun as I talk to plastic surgery experts, friends, and real-life patients about all things plastic surgery. Should be fun. Hey guys, the episode you have been waiting for and asking for is finally here. We're talking about BBLs, everything you need to know with the GOAT, Dr. Azizi out of Chicago. You guys cannot miss this. Dr. Azizi, thank you for being on the show with me today. I'm so excited to have you.
Thanks a bunch, Mavi. It's a pleasure. There's so much to talk about. So thanks a lot for having me on.
You know, BBLs have been the topic of discussion lately. And I think more and more in the headlines and adding more to the confusion. This episode, I want you and I to kind of clear the air. Let's get some myths out of the way. Let's get some stigma out of the way. And let's answer these questions that our patients have or our girls have. And they're getting stuck in, what's it called? It's like indecision.
Analysis paralysis.
Yes, analysis paralysis. Yeah. That's what it is. They're stuck in analysis paralysis.
There's so much craziness out there. And I see it, and I'm doing this work all the time. And BBLs is one of the most common thing, probably the most common surgery that I do. And I see it all the time. And I see stuff on Instagram and online, and people send me these videos. And I'm like, it's hard to just write something back on Instagram or do a little thing about it. So I'm like, I like this because we can actually talk a lot about it. There's a lot of things with BBL and like safety and shapes and like surgery and recovery and all this kind of stuff. There's a lot of things that are black and white and really well elucidated. And you're like, okay, we know that, okay, you probably shouldn't sit on the butt for a bit of time. But there's a lot of gray areas too of like, well, how long? Or like, well, what are the safety concerns? And obviously like safety is super important. It's super important to me, and any of my patients will tell you that. But like these days, it's so hyped and there's a lot of attention grabbing headlines. And so, that's one of the things I wanted to talk about also is just, what is the truth? What do we know? What do we don't know? And, stuff for people to consider.
Exactly. And I'm so happy to have it come from the actual surgeon's mouth. You guys, this is not coming from your friend who might have had a BBL, a few years ago, or somebody else who heard it from somebody else. Like this is coming straight from the horse's mouth.
Yeah.
So I think the number one thing, you guys, let's treat this like a mock consultation. So I'm going to ask some questions. Dr. Azizi will answer them and give us some more information. And if you think there's something I miss, Dr. Azizi, put it in there. Let's give these girls as much information. And let's start with BBL safety. So we know it's in the headlines that BBLs are dangerous. And I have on my Instagram tried to put it out there, the difference between a dangerous BBL, which there is dangerous BBLs being performed out there, but not all BBLs are dangerous. We are taking risks. Anytime we go under general anesthesia or surgery or anything, we are taking a risk, which yes, we are, but it's very different a risk to danger where we're doing something dangerous. And I think if we could really dive into the safety of BBLs and how they're performed and which way is the safest way, and just give us everything we need to know.
All right. Awesome. Okay. So yes, BBL safety, most important thing, because it is a surgery. If you don't perform it in a safe fashion and doing certain things, it can not be safe and it could be lethal, right? So that's obviously sucks. It's, everything we do with surgery is all calculated risk. And what we're trying to just do is minimize the chances of risk and minimize the chance of complications as much as possible. It's like when you drive to work, you're trying to minimize the risk, right? You can get into an accident and you're trying to minimize that by
wearing a seatbelt,
coffee in the morning. Yeah. Wear your seatbelt. Be paying attention, blah, blah, blah. The flip side of that is you could be drunk driving and you could have not slept, or you could not wear a seatbelt, right? So there's ways of doing that routine thing dangerously and not dangerously, but we don't really worry about that when we get in the car. We're not super thinking about an accident. We're just trying to do it the safest as possible. And the same thing with surgery, right? So BBL specifically, we try to set it up to be as safe as possible. So I'm just going to do this kind of how I talk to patients. Patients will always ask I'm worried, or I'm worried about anesthesia, or I'm worried about this and that. So first of all, it's funny because a lot of people worry about anesthesia, but anesthesia is one of the safest parts to it. And if you're a healthy person, if you don't have any big medical issues, and by big medical issues, I mean stuff like diabetes that's not controlled, high blood pressure that's not controlled, if you're not like really overweight, these kinds of things that increase the risks of anesthesia, then anesthesia is super safe. And the chances of like a death from an anesthesia is around 1 out of 100,000. So it's super low, right? So anesthesia is usually the safest part, but sometimes the part that people worry about the most when it comes to this kind of thing. Me specifically, a lot of other surgeons will usually get a medical clearance. We get a lot of blood work, EKG, just to make sure that there's no like underlying stuff that could potentially pop up or be an issue. All right. So anesthesia is super safe. Other than that, I just tell my patients that infection and bleeding, only about a 1% chance. So it's not too often to run into infections. It's pretty rare to have like a bleeding issue where we have to go back and fix it. So those aren't really the big things. So obviously what we worry about with deaths and BBL and the safety stuff is pulmonary embolism. And what that is when you're injecting fat into the butt, and if some of that fat gets into one of the big veins, and it travels up to your heart and your lungs, and it can cause a serious issue. And that is what can cause death, right? So we don't want that. But there's a lot of ways to prevent that. So let's talk about like the hype and why are we even talking about this stuff these days? So about in 2018, so now about 3 years ago, a study came out that showed that the death risk in BBLs was 1 out of 3,000, which is really high because death risk in like a tummy tuck is 1 out of 10,000. So think of it as like our tummy tuck is kind of our standard. No one is saying, hey, we should stop doing tummy tucks because they're so darn dangerous. And it's a 1 out of 10,000, which is actually, really good, right? So people were really worried because they're like, oh, there's people actually dying from this. Now, that study that came out at that time had a very few number of patients they looked at. It wasn't like a big study. It wasn't looking at a lot of surgeons. There's a lot of self-reported numbers and data that wasn't really that good. And it was kind of flawed. And it wasn't like a strong study, but it's very easy to take that, put it into a headline, and then people start talking about this. And it was probably a conversation that was going to be happening because BBL was getting way popular in the last 10 years. And anytime anything gets popular, there are conversations that happen around it, whether good or bad, right? So since then, safety-wise, a lot of plastic surgeons who do this work, plastic surgeons and cosmetic surgeons, started looking at the actual numbers. And a lot of studies have come out since then, looking at much higher numbers, like 20,000, 30,000 people, this kind of stuff, looking at many different countries and the different ways of it being done. And they showed, the more recent studies, multiple of them, showed that when you do it safely and when you're not trying to inject the muscle, and we'll get into that, the chances of death are more like 1 out of 20,000 to 1 out of 30,000. So it's very low.
That's a big jump in numbers.
Huge jump. Yeah. And it's like, it's just because you're looking at it from when you look at more numbers and you see that this thing can actually be done safely, it's a huge difference. But the 1 out of 3,000 thing is what gets a lot of the headlines. And then 1 out of 30,000 thing is boring. No one wants to talk about that. And it's kind of like whoever gets in the game first. Like, well, it's the 1 out of, if they came out and said like BBLs are one of the safest surgeries ever, that first study came out, then that would be like perhaps the headline or something, But then what happens, the other thing that I see online often is a lot of these people who are so-called experts or experts in plastic surgery that are talking about this are not people who actually perform this surgery a lot too. So the people that go online or on TV or whatever who are like, oh, we shouldn't do this or I don't do this. It's like, well, dude, you weren't really doing that much of it before. You were doing like 1 every 2 months. You weren't that good at it. Your results aren't that good. You probably don't like doing it because the surgery is actually physically demanding. So a lot of plastic surgeons don't often like to do it because it's physically demanding.
It's
it takes
exhausting.
A lot to,
yeah.
Yeah.
It's a lot of arm work.
Trust me, I know. It's like, that's actually one of the reasons why I only do one big case a day, because my patients know this. I talk to them all the time. Basically, I do like a 3 to 4 hour BBL. It's like you're rowing for those 3 to 4 hours. I don't have like an assistant doing my lipo for me. I do everything myself, all, thousands of strokes of the lipo. I'm doing it, injecting all this kind of stuff because safety is number one. Because of that, it's physically demanding. People get tired. So these surgeons who talk negatively about it online, these aren't usually the ones who are doing a lot of this stuff. And obviously there's a bias, and obviously I'm biased, right? Because I do this work. And so I'm biased towards talking about it in a safe way, but it's kind of like the truth, and you can look up these studies and they're out there. So a lot of stuff that's out there, a lot of the surgeons are hanging on this study that was 1 out of 3,000 deaths, came out years ago, that since then has been shown to not be true, shown to be a lot safer, but that's kind of still what they're talking about. And it's kind of like, so I don't do a lot of face surgery anymore. I don't do like facelifts or rhinoplasties, this kind of stuff, because I got so busy with body work. So, you wouldn't come to me necessarily to do a facelift, and a facelift with me may have more complications because I don't do it as often. It's just like you wouldn't go to that facelift surgeon who's on there talking about the negative stuff about BBL and ask them for a BBL. because they just don't do it as often. They're not going to be probably given like the best results. Maybe they're not going to be able to kind of ride that line of we're trying to maximize results, take as much out with lipo, but also get you through surgery safely and get like, minimal risk with like the butt injection. So that's a lot about the numbers and the kind of the lethal stuff and the not lethal stuff. And what does it actually come down to? So then we should talk about, well, what causes like the death of the pulmonary embolism and all this kind of stuff. And what do we do to prevent that? So it all comes down to muscle injection when it comes to the fat. Okay. So in the butt, if you start from the top layers, very simple. It's skin, then there's fat, and then there's muscle / what we call fascia. And fascia is like a tough fiber that kind of runs along the muscle. Okay. So when we inject in the butt, the safest way to do it is injecting only in the fat. All right. So when we inject it in the fat layer, which is above the muscle, and we try to keep in that layer because there are no like large veins and all that kind of stuff is not sitting in that layer. So that's a very safe layer to inject. And what we found in those studies is that when people inject in these layers, you decrease the chance of death to 1 out of 20 to 1 out of 30,000. So very low, very acceptable for surgery. Now, why would people, the question is like, well, why inject in the muscle? So people inject in the muscle either accidentally or on purpose. Okay, so why would you inject on purpose? So on purpose, people inject because you can maybe get a few hundred more cc's of fat in there. All right. Also, historically, let's just say like 10 years ago, it wasn't considered as bad to inject in the muscle. So when I'm doing my training in my plastic surgery fellowship, and this is about like 5 to 8 years ago, at that time, BBLs are starting to get a little more popular. Not a lot of people are talking about them online still. Amongst the community in plastic surgery, we knew that like, well, you can inject in the muscle, you can inject in the fat portion. And we knew that there was kind of like some pulmonary embolism stuff and some of this stuff happening. And it seemed like the discussion anecdotally was around like, well, it's probably if you're injecting the muscle or injecting deep and it's going up into the lungs. So it's probably not a good idea to do it. But it was still considered like, okay, because a lot of people worldwide were still injecting a little bit in the muscle. And there were these thoughts of like, well, if you just inject in the superficial high layers of the muscle, maybe it's not so bad. Oh, if you don't inject that much, it's not so bad. But then cadaver studies and anatomic studies since then showed that if you inject deeper than this muscle or deeper than the fascia fiber layer that we were talking about, basically underneath the fat and not in that fat layer, what happens is that the pressure of that fat can push that stuff right into those veins and then send it up to your lungs. So the idea is that we're trying to not inject in the muscle anymore. And I don't know any like respected plastic surgeons who are injecting the muscle, and all of us are trying to basically inject in the fat. Even back then in my fellowship, even when it was considered like okay or maybe acceptable to inject in the muscle and people would still do a little bit of it, even then I was like, dude, I am not taking this risk with my patients just to get a few hundred more cc's in there. Like, Can you imagine like like you're on the table. I always tell my patients, I'm like, they're worried about safety. I always tell them like, look, dude, I need to call someone's wife or husband or daughter or mother after surgery and tell them that this person got through surgery all good. And I'm not trying to take a risk getting a few hundred more cc's in there for, and risking a patient dying just to get a few hundred more cc's. Like that's what a round 2 is for. That's what a round 1.5 is for.
Yep.
So in surgery, we do a lot of things to make it so that, remember I said, I was like, there's 2 ways things happen bad. Either you inject on purpose, which a lot of people don't do now, or you inject accidentally into the muscle or like under the muscle. So I try to set it up in ways where I don't even accidentally do it. Try to set yourself up for success. So I bend the table in a certain way where like the muscle kind of falls downward and the field that I'm working on is upward. I have angled instruments that go upward. I like to use kind of bigger, blunter instruments rather than small needles to inject, because if you think of it, I always use the analogy of if you have a pencil and you have the sharp end, you got the eraser and you got a piece of paper and you try to poke through that piece of paper. Now let's say that piece of paper is your muscle. It's a lot easier to poke through that paper when you have the sharp end of the pencil rather than if you're trying to poke through it with the blunt end of the eraser, right?
Yeah.
So the instruments I use are more like the blunt end of the eraser so that if they do hit the muscle, they bounce off of it and you can feel them better in there. And so I'm trying to make it so that it's hard for me to even accidentally inject in there. And other cadaver studies even showed that from certain angles. So specifically, you're not trying to inject down low. So down low and like kind of inward towards like the inner thighs, that's kind of the danger zone. Up top of the butt, not the danger zone. It's down low and the kind of inner. So when you use an angle of like at the top of the butt crease or the butt crack, right? When we use that little poke hole, top of the butt crease, to then inject downward into that dangerous zone, it's actually shown in cadaver studies to be almost impossible to get into or under the muscle from that angle. So you can do these things in surgery, like set yourself up for success and make it tough to even inject into the muscle. And that's like one thing I do. I know that like, oh, when I'm injecting into this area that potentially could be dangerous, I'm going to inject from an angle that is shown to be like almost impossible to get in the muscle. So that's the gist of it. That's kind of like the hype out there. That is like what we can do. Like that's why people get pulmonary embolisms. And avoiding injection in the muscle is what we're all trying to do these days, or we should be trying to do. There's people out there who are still doing it. I think I totally disagree with it. But a lot of us who are trying to do good work and do it safely are doing it in these ways to try to set ourselves up for success.
I agree with you. And let me just tell you something that I heard from a patient during a consultation. When I told her that we don't inject below the muscle, she told me that she had a consultation where the doctor told her that the only way she could get the bubble butt that she wanted was if he went under the muscle.
Yeah. And that may be true, but are you willing to take that risk? I think that's crazy.
I think it's ridiculous, but
yeah, listen, it's crazy. But here's the thing, like some patients want that bubble butt so bad, they'll be okay with taking a 1 out of 3,000 risk of death to get that bubble butt and get some fat underneath the muscle, for instance. Some surgeons, well, that girl was probably lucky that the surgeon actually told her that I'll inject the muscle. Because there's some surgeons who would inject the muscle to get a better result and not tell you necessarily, And then some of them will actually tell you like, look, yeah, I'm going to do it. I'm doing the superficial layers a little higher, so maybe it won't be as risky, but yeah, I injected the muscle. So, I mean, I disagree with them injecting the muscle. Props to them for being ballsy enough to actually tell you that and kind of, but also they're just being honest. So it's true. I mean, here's the thing. There's a little cosmetic improvement perhaps in some people if you inject in the muscle, but is that worth it? To me as a surgeon, I think it's crazy. It's not worth it to me. And it's way better to just give you a little bit more fat on that second round if we need to. And we don't even need to in most people, than to increase this risk of death and like have that,
I 100% agree. You guys know that I'm never going to tell you, I'm not going to push you in that direction ever. Yeah. Do the safest way. If you need a round 2, if you need a round 3, better to do it that way than to take a higher risk on round 1. Mm-hmm. That's my stance on it. No, don't do it. You guys don't do it.
Yeah.
Okay.
So there you go. Yeah.
So let's talk about the complications besides the pulmonary embolism. You have infection, which honestly here, like from patients that I've had here, it's so rare. We really don't see infection very much, but we have patients who are leaving the country and they're coming back and they have infections. So why? What is it? Just like their sterility of their instruments? Is it how they process their fat?
I think it's cutting corners. And I've been in a lot of, like over I did like 8 years of residency and I worked in 20, 30 different hospitals and surgery centers and all this. And you see some places when they start to cut corners, right? So there's a certain standard that we have in the US that is usually high when it comes to sterility, right? Mm-hmm. And when we operate in an operating room or a clean surgery center or this and that, we usually can get things by with a very minimal infection risk, like very, very low, right? Like 1%, like I said, which is very reasonable. I see more infections when people start to go overseas, and not that overseas, there's a little bit more risk. That's a whole nother discussion. We can get into that too.
That's a whole nother episode, you guys. That's a whole
nother episode. Not even a discussion. That's a whole episode, man. That's a whole nother podcast, But anyway, what do I see more of? I think when people go to more of the chop shop type places where corners are being cut, and I've worked in some of these places where I've seen them, not like worked meaning I've operated like at the same facility, and I've seen these places where the surgeon is like barely in the room coming in and out. There's like random people coming in and out of the room. You don't follow these things of like the door should be closed, minimal people in the room. Everyone should be wearing like either sterile or sub-sterile clothes when they're in there. It's a little bit more open, right? And then when that happens, corners get cut, a little more bacteria is hanging around, a little bacteria hits the instruments, you're increasing your chances of infection. That kind of thing happens. What I've seen from people who go overseas, it's like you just don't know what their standards are. You don't even know if even in the US, you don't know if someone's a plastic surgeon or a cosmetic surgeon, or someone took a weekend course and they're like an ER doctor, took a weekend lipo course and they're doing your BBL now, Mm-hmm. So, they don't know what they don't know. It's that level of risk, So when people go overseas, we even know less, right? So what I see more often for people going overseas is come back with certain bacteria that are actually multi-drug resistant because we don't know what the standards are there. There's probably a lot of corner cutting going on. And people come back with bacteria that are like really hard to even fight with antibiotics and like surgical drainage and all these kinds of things that we do.
Wow.
So
really?
Yeah. Yeah. And if you talk to a lot of surgeons, you'll see that like, when we get infections here in the US, the infections are kind of like the normal bacteria that we usually get infections with, which we have good drugs for. When people go overseas, we start to see like funky stuff like mycobacterium, which is like really hard to fight, or like multi-drug resistant bacteria, which is really hard to fight. And people will have these like draining wounds or whatever for like months at a time. And no matter what you do with antibiotics or drainage or take them to the OR and clean them out and this and that, it's really like it takes a lot longer to fight that. The hope is that if we get an infection here in the US, it's like, oh, we'll just drain it. The pus comes out, thing heals up in a couple of weeks. Oh, we're good.
We'll put them on some antibiotics. They're good.
Yeah, that should be how it is. I've certainly seen worse. I've seen people who, when I was in residency, people who are either here from the US or elsewhere who got more sick. But I think it just comes down to the less of a standard that the facility has, whether it's in the US or outside, the more corner cutting, the less sterile concerns and stuff. And, it's just the increasing chances of bacteria getting on everything and then that bacteria getting inside you. So
got it. I think, that's why I think Annalisa in a previous episode said, here in the US, we got the FDA in our back pocket taking care of us. Mm-hmm. And in other countries, we're not sure who's taking care of us, who's regulating, who's really, out for our protection. So that's why I always encourage you guys to stay here unless you're going to see somebody just because, nobody can give you the results like this one specific surgeon who's out of the country.
Yeah. And there's fantastic surgeons outside the country,
there is definitely
more hit or miss.
It's more hit or miss, but there is good surgeons outside of the country, but we have good surgeons here. There's no need for you to travel, and add additional risk and cost that you don't really have to, because we have great surgeons here. But and practically speaking, not just FDA, but like, here in the US, it's like more litigious culture. So like as surgeons, we're more concerned about like getting sued or people complaining or going talking smack online. If you're out of the country, like, listen, a lot of people know that they're never going to see you ever again. They give you infection. I've seen people like with open wounds, they just throw some pads on there and put them on a plane, drains, this and that, send them on a plane, and that's crazy. And they know that they're never going to see you again. You're not coming back. You can't sue them. You're not going to get your money back. So there's like less impetus to do good. Potentially, they're like that part of that kind of the fear of like, oh, what if I get sued? Oh, what about my reputation? Oh, what if this person comes back? Like if you're not going to see someone and your assistant is the one doing the lipo, there's just less quality that you're going to be getting out of that surgery when you go get it done. I 100% see it, and I agree. Okay, so we talked about safety. All right, I hope you guys feel like you've got some good answers. Now let's talk about probably the second thing I hear the most, which is BMI and the importance of where you are on the scale of your BMI. And after Dr. Azizi tells y'all his portion, I'm going to tell y'all why it's more important to me, why I feel like it should be more important to these two girls who are considering surgery.
Yeah. So BMI, whole discussion, it's a really good question. And you should, we'll break it down into different ranges of BMI. And just really simple, for anyone who's never heard of it, BMI is body mass index. It basically takes your height and your weight, and you can find a million calculators online to calculate it. And it'll give you a number. So people who are skinny are more like 18, 19, 20 BMI. And people who are kind of like in medium are like maybe 25 to 30. And people who are obese or morbidly obese are like 35 or 40 or above, for instance. Okay. So there are pros and cons in all these different areas when it comes to getting surgery. The studies, so in general, the studies show that no matter what surgery you get, if your BMI is higher than 30, then your chance of infection and DVTs and blood clots and these kinds of things, complications goes up. Okay. So that's one reason to kind of try to get your BMI lower than 30. All right. Now, practically speaking, I have found when people are like a 35, 40 or higher BMI, you usually have more issues with high blood pressure, diabetes, maybe like lung issues, this kind of stuff. It's hard for someone or it's less often that you see someone who's a 40 BMI who has less of these issues. And those issues, remember we talked about the safety, like first we got to make sure that you can get through anesthesia. right? So like if you have more of those issues, it's just hard to even put you to sleep and not even do any surgery, let alone if we're trying to do big changes type surgery, right?
Mm-hmm.
So that's why it's harder to do surgery on someone who's like 40 BMI, for example, right? Because it's just harder to put them through anesthesia. The other thing to keep in mind is how much can we lipo off people and to make people happy, all right? So a lot of people know if they've done, any kind of research online that the safe limit or the number that's thrown around is around 5 liters of lipo that we can remove in one round, all right? So 5 liters, what happened? Well, why not less? Why not more? Okay, so 5 liters, when you remove 5 liters off someone, most people, the vast majority of people, can do fine with that. They have a tough week and they bounce back from it. Good hydration, this and that. But when you start removing more than that, people have more issues with blood pressure or maybe passing out or losing more blood. Now, 5 liters is not the same in everybody. All right. So like if you take a girl who's 20 BMI and take 5 liters off of her versus someone who's 35 BMI, it's going to hit the smaller girl a lot harder. The smaller girl is going to have a harder time. So yes, you can take a little bit more off people who are 35 BMI, or let's just say 40 BMI, right? So as you go higher, you can take more off those people. There's certain medicines you can give in surgery that kind of help to reduce bleeding, so you can take a little bit more off. But practically speaking, I have found that, like, how much do you need to take off to make people happy? So when you're at a 30 BMI or less, the excess amount of fat that you have around your belly is usually around 5 to 6 liters, let's just say. All right. So like that's someone that could get through one round of Lipo 360 or BBL, and we can get them happy and get them snatched and looking good because, they're only hanging around with maybe 5, 6, 7 liters on their midsection. So if I go in there, I take 5, 6 liters off someone who's 30 BMI, I took like 80, 90% of that fat off their midsection, we got a really snatched body. Someone who's 35 BMI, I find that they have more like 10, 11, 12 liters of fat around their midsection. So these are people that, just because of the physics of it and how much fat you have there, often then need 2 rounds if you really want to get snatched. All right. And so, the thing is, like, why can't we go higher than 5, 6 liters? Just the bodies can't tolerate it. It's just really hard. You start pushing like 7 liters on some people or 8 liters. Like now you need to either be admitted to the hospital for IV fluids, or maybe need a blood transfusion, or maybe you're passing out at home more. Those are things that we don't want to do with elective surgery, right? So those are kind of the physical reasons. Like, well, it's just easier to make someone happy and get them snatched if they're less than 30 BMI, because everyone wants to get snatched in one surgery. People don't necessarily want to get like 2, 3 surgeries to get snatched. And so it's easier if you're a smaller BMI, plus you have less chance of infections, this and that. All right. Now, other things to keep in mind is when people get a little bit higher, like a 35 or a 40 BMI, you start to stretch out more of the skin. And then you may need more stuff like a tummy tuck, versus if you had lost a little bit more weight or you were a bit lower, maybe you wouldn't need that tummy tuck. So it's like, you then need extra procedures to make you look better or snatch or get to your goals, right? Now, it's not like it's all roses for people who are 18, 19, and 20 BMI, people who are skinnier. These are like the skinny BBL patients. This is a little bit different challenge. So with these patients, these people have a hard time gaining weight. And this is not me.
That's not me, because I look at food and I gain weight.
Yeah, seriously. I know. Oh man. I drink a sugar-free Red Bull. I put on like 5 pounds, So you got these girls who are 18, 19, 20 BMI, and they may need to like put on some weight to do surgery, or we need to go for like thighs or arms to get all the extra fat. And then, you transfer the fat. And the hard thing is that if these girls have a hard time putting on weight to get surgery, they have a hard time maintaining that weight after surgery. So then if you lose weight, you may lose some more of it from your butt, for instance. That's a whole other discussion. Like we'll talk about that too, but it's hard to maintain. So the idea, all it comes down to like is minimizing complications, maximizing cosmetic results, and maintaining cosmetic results, right? So how do you do that best? If you're getting down to your target weight and you're not going to like lose more weight and you're down to a skinny weight that you're happy with, then you know how to stay at that weight typically, and you know how to, keep your cosmetic results because you got your weight down to a 25 BMI. Let's just say we did a surgery. You know how to maintain that result. Minimizing complications. Studies show it's 30 or less. That's a good way to do it. It's not that you can't do it safely on people who are like 35 BMI. It's just complication risk starts to creep up a little bit, and you got to make sure you're doing it good. You're not pushing the limits of what the body can handle. You're doing it super sterilely to minimize infections. Maybe you're not tugging the tissues as much or pulling that, trying to snatch that tummy tuck as much as possible, because there's more tension on the wound, and people with 35 BMI have more wound issues. So you're trying not to like do that. So you can get a better snatch if you're like a little bit smaller. And so all that stuff is what it kind of comes down to. And then minimizing multiple surgeries. So if you're like 35, 40 and you have like goals of really trying to get super snatch and rounded butt, this and that, you will very likely need multiple surgeries to do it because there's limits on what the body can handle in one surgery to get you to that goal.
Safely.
So that's kind of a lot of
safely.
Yeah. Safely. Exactly. Now, yeah, I could sit there, keep sucking and take 10 liters off you, but your body's not going to handle it. And in some other countries, they'll do that. And, you know, they don't post the girls who end up like blood transfusions and in the hospital and all that stuff. But like, yeah, if your body can handle it and you're some of those girls who like survive that surgery, you're going to be super snatched. It's going to look amazing.
It's going to look great, but you're taking the very big risk.
Exactly. I'm not trying to get like 40% of my patients like in the hospital overnight getting blood transfusions and stuff just so we can snatch more people, you know. You can get a lot out of it, but it's like just get, you know, in general, you want to get your weight down to a good target weight, a good goal weight, and then get your surgery to kind of make it that last like hump, you know, or like get you down to like where like, oh man, the stubborn fat is just not going anywhere. Different discussion if we're talking like tummy tucks and like the muscle stretching. Like if you've had kids and your skin is like stretched, you know, like all the gym and all the, you know, waist training, all that stuff that you do is really not going to help that skin to like snatch back. It's not really going to help your muscle to like tighten up. So that's when you do need that tummy tuck to do the muscle repair. You do need to remove that skin to get that going, you know? So that's a little bit different discussion. But when it comes to pure BMI, getting your BMI down lower is like minimizing complications, maximizing your cosmetic results, and ultimately maximizing happiness, which is what we're trying to do with all this stuff.
Absolutely. So let me tell you guys why I feel now more strongly about making sure that you're close to your goal weight. Because when I had my procedure in 2018, I had a tummy tuck lipo 360 BBL, and I was at a higher BMI than what I am currently. And I feel like as I stayed at that weight for a while and I was very happy with it. But as I got comfortable at that size, my weight went up. So now that I've gotten my weight back under control, I'm working out, eating right, I see the skin irregularities now after I've lost the weight. So I think that's something that should be like, you guys, when we do liposuction, there's no guarantee that there's not going to be any irregularities. And I think that they're augmented when your weight fluctuates. Do you think that's right?
Yeah. You know, it's like if you get your weight low, let's say, and we're trying to do the surgery and using all these different techniques to make as smooth results as possible and minimize contrarregularity. We always say about like minimizing, right? Because there's no guarantees. There's nothing that's zero. Zero is like not getting surgery, right? They're like, you know, that's the only time you're going to get zero risk, but you're trying to make things only a 1% or a 2% risk, right? So if you have like, you get your body right, we do an awesome BBL on you, lipo, everything looks really good. And there's always going to be differences in the left and right side of the body, just because that's how everyone is, whether you've had surgery or not. So that's kind of just normal humans. And there may be, let's say your left side, your right side of your abs or something has 3 millimeters or less or more, for instance, of irregularity. Now, 3 millimeters, you're like not going to notice that if you're looking at it. But if you gain weight, it's going to kind of start to magnify some of these things. So it's just going to make asymmetries kind of bigger because you're going to kind of gain weight in the thicker areas of fat a little bit more and like at a bigger rate. Now, if your body's all good, that thicker area of fat is your butt. And so you gaining weight, you gain 5-10 pounds, you may actually like that because why? Because your butt got bigger and rounder, your hips got better. And your abs, yeah, they got a little bit more weight, but you actually like your new weight. So I always tell patients that there may be a new weight after surgery, or more likely there's a new weight after surgery that you're going to be happy with, X. And that may be a little higher and a little bit lower, 5-10 pounds or so. But it's true. I've had patients where I see them at the 1 month visit and then I see them at the 3 month visit and they've put on like 20 pounds since then. And it's like,
it's the girl a slippery slope, man.
I know. Listen, and I'm not even judging because like I will put on 20 pounds this weekend, like just planning on like what I'm eating. You know what I mean? I didn't even get surgery or anything. So I know it's easy. And I'm in Chicago, and Chicago's got a lot of great food and I love eating. So I know it's easy. I'm just trying to like say, what are the risks with this kind of thing? So I've seen people from the 1 month visit to the 3 month visit, put on 20 pounds, come back and be like, well, this looks like this, or this looks like this. And you should be getting smaller at your 3 month visit because you just still got swelling. You should be looking like even better than the 1 month. And then we weigh them and they put on 20 pounds. And it's like, well, this is kind of the reason that we're here. And it sucks. It's demoralizing either for patients or the surgeon too, because we want to do awesome work. And it just sucks. Like, yes, we all are going to creep in weight over time, a couple pounds here and there, 5 pounds, 10 pounds here and there, especially women with their cycles and all the fluid shifts, like they're going to creep more than men will. But, it's just a darn shame if you pay this money, you go through this recovery, and you just put on that weight, and like within 6 months or a year after surgery, it just kind of sucks.
It really does suck, you guys, because I did it. I gained it. And then I got used to my big old butt. And now I'm trying to get back to a normal weight. And I'm like, hey, my butt's going away. I got used to it being the way it was before, but I like my waist better the way it is now. So take it's the warning for me. Just be where you want to be at your weight, 10 to 15 pounds max, to get the best results.
Yeah.
Pretty much.
It's it's like all plastic surgery. You got to kind of get your life right before you get the plastic surgery. The plastic surgery isn't necessarily going to unlock like this super happiness in your life. It will make a big change, but it's kind of like how many stories you hear about lottery winners. They get, $5 million and then they're back to being broke after just a few years.
Yeah, that's crazy.
Because they didn't get their financial life right, let's just say. And so like you're getting your body and your weight life right is like the surgery is like the lottery. And it's like, if you don't get it right and we just give you all the surgery, or you pay for the surgery and you get all the surgery, you go through recovery and all that, and you haven't figured out how to maintain your weight at a reasonable level and kind of keep it, then you're just going to kind of blow those like lottery winnings, so to speak.
Yep, definitely. Okay. So now that we're on the subject of the irregularities and liposuction, let's talk about VASER. So tell me, the 2-hour BBL versus the 4-hour BBL and VASER. Let's talk about it.
Yeah. All right. So this gets into like techniques and technologies, right? And so a lot of surgeons have different techniques and technologies they use in surgery. And it's not that one's the best or one's the total right one. It's more like, think of these as like different paintbrushes for an artist, right? So if you like a certain artist's art and they can deliver that art with certain paintbrushes, it doesn't mean that they're not using the right or the wrong ones, So like for me, for example, I do surgery in a certain way. I use certain tools and techniques because I want to deliver the best results that I can deliver. And what that is like, I want to be able to do high definition. I want to be able to minimize contour irregularities, improve smoothness, help with like skin retraction, less bleeding, all this kind of stuff. So let's just talk real basics. So liposuction. So basically in lipo, essentially, the first thing you do is you put in this, what's called tumescence. Tumescence is like water with a little bit of lidocaine in there to help with like pain, and a little bit of epinephrine in there. Epinephrine is adrenaline, and that is really important because it helps to decrease bleeding. So we put that into all your tissues. It helps to break up your fat. And then we can go in with the suction cannula and suck out that fat. That's like lipo at its most basic. Put in the water, break up the fat, suck it out. Cool. I use something called VASER, and VASER is a technology that's been out there for 20 years. And it uses so like after you put in the water in, you use this kind of long prong or it kind of looks like the cannula from lipo, but it doesn't actually suck or anything. And it has an ultrasound tip to it, and it gets in there and starts to break up the fat. Little mini shock waves to kind of help break up the fat. And it basically takes the fat and makes it from like let's just say like a cold butter that's really tough to like a smooth, silky olive oil. All right. And so that helps to suck it out less traumatically. So what I found is that helps to like have less bleeding, which means that I can lipo a little bit more, which means that like the more that 5 liters that I'm removing off here, that 6 liters, more of that is fat, less of that is like blood and random like fluid, right? So we want to remove more fat. Awesome. You get less bleeding, you get less bruising. You get less bruising, you get less swelling. Okay, so these are all awesome things. And then what I found, why do I like to use VASER? Because my results got smoother and my results got better once I started using that. All right. And I'm talking about like stuff like high definition. So when I would create the abs on the table prior to using VASER, and then I would see the patients later, the abs would not be popping as much. And then once I started using VASER, the abs started popping more. Another important part of that, post-op protocol. So like massages, super important. Massages also, I would create the abs on the table. We wouldn't see them post-op. And then people started getting massages and boom, all these abs started popping afterwards. Okay, awesome. So it's like the post-op protocol techniques are all important. So when it comes to VASER, I like using it, like I said, because it decreases bleeding. We've got less bruising, less swelling, improved results. We can do more like high definition. All these things are good, but it adds time. All right. So a BBL, then, I can do like a quicker BBL. A quick BBL is like 2.5 hours, let's just say. All right. A smaller person, not a lot of fat, or perhaps a bigger person with more fat that, flies out easily and we get to that 5 liters limit. 2.5 hours. Once I started doing VASER and like increasing all these techniques and doing a high def and, not just sucking the fat and, stuffing it back in the butt, things take longer, they add time. And now, the BBL maybe takes like 3.5 hours or 4 hours or something. But it's kind of like if you were going to like paint your wall at your house and you're using a big old brush to paint it, you're going to paint that wall a lot quicker. But if you're trying to like paint a mural on your wall and you're using little fine brushes, it's just going to take longer. So when we're doing stuff like high definition, creating abs, or trying to contour and create a toned look in people, it's just going to take a little bit more time than sucking the fat out and putting it back in. And it just depends on what does that surgeon want to do as far as what kind of work they want to put out there. I want to do like the highest level of like lipo, which I feel is high definition and creating these awesome contoured and toned bodies and that kind of thing. Now, there's a lot of surgeons who do the surgery quicker and, they want to just suck the fat out and, snatch you and then like stuff it in the butt and you have a big round butt and hips. And that's cool. It's just kind of different philosophies as to like what we're trying to create necessarily out there. And then what I said at the beginning is like, just go with the surgeon that their work kind of reverberates or kind of, you vibe with, right? So like, if you look at my work and you love it, awesome. If you look at my work and someone else and you can't tell the difference and that other person has like, I don't know, lower prices or something like that, like maybe that's fine. And you don't need to necessarily go to me and, you can be happy. There's no like, it's like different bands and music. No, it's like everyone just chooses what they like. It's like
different choices.
Yeah. Different flavors of ice cream, right? So no one says that there's one best flavor of ice cream. You know what's best for you, but like, and there's like cars, so there's different styles of the butt, right? So some people have a more exaggerated look. Some people have
that's
a
perfect.
more...
Let's talk. Let's go into that. Let's talk about shape of the butt and the different trends that we've seen.
Yes. So, okay. So shape is a big deal. So after we finish talking about like safety stuff, patients always want to like talk about shape, right? So basically the two biggest shapes that we talk about are a shelf or a slope butt. Okay. And these are referred to in different ways. So a shelf is more like when you have more perkiness up top and it kind of like your back goes down and then it really pops to the top. Also, it could be called like a bubble butt or like a much rounder thing. A slope is where there's more gradual transition from your lower back to your butt. So you have more bottom butt heaviness. Okay. So it's kind of like if you look at a heart, a shelf maybe more of a heart shape where it's like more up top, it's full. And a slope is more of an upside down heart where the bottom of the heart is full. Now, I've seen these terms used kind of interchangeably, so I don't mind looking at photos of what patients like because sometimes someone will say they got I like a heart-shaped butt, and they show me photos of like the opposite of that. No, exactly. And so these terms are not like standardized. It's just like, what do people like, right? And forget about like hips and lats. That is that is a whole thing, dude. That's like once that discussion started coming out, I was like, oh my God, this is going to confuse so many girls because it's like, it's so confusing, So like shelf and slope, at least we can all kind of agree on what that is. Hips and lats, no one can agree on what that is. And I'm happy to talk about that too.
Yes, so let's dive into it. I hear about it.
Talked about, oh my God, let me finish like the shelf slope talk first, because that whole thing is like, I need more of my Red Bull before I can get into that discussion. So what have I found with trends? Now, I find these days people are asking for a slope and more of a natural transition down to the lower part of the butt, more bottom heaviness. And previously, in the last 5-10 years, people would just put in as much fat as the butt they would take. Or, we've usually put in more fat at the top of the butt because that's more anatomically normal. Because like if you're looking at a perky butt, it's more the top of the butt that's perky. That's where the muscle lies, meaning that when you're hitting the gym, and what we know of a good perky butt is you're hitting the gym, you're doing your squats, you're doing all your like butt exercises, and the top of your butt is going to get more perky. And so that's what humans and kind of aesthetically we usually like. And that's why we generally would inject more up top. What I think has happened is that in the last 5-10 years of, let's say, bad BBL results, where people would have like super exaggerated shelves up top and like people are just, it's like a pendulum. Pendulum swings back and forth when it comes to fashion, right? Things go from exaggerated to minimal and exaggerated minimal. And like music is that way. And like, so, and everything swings back and forth. I think that people saw a lot of bad shelf booties that they didn't like, and a lot of that up top fullness and perkiness they didn't like, and it looked too unnatural. And so I get way more people now that ask for more of a slope, more of a natural or a smoother transition from the lower back to the butt, and more bottom fullness. I think this is also the look that you see more with high-waisted jeans now. So if you see a lot of girls out there looking good on Instagram, looking good in general, and high-waisted jeans have gotten bigger in the last, let's say, 3 years or so, this is that look of like the jeans are kind of hiked up and that booty at the bottom is more full and it looks like an upside down heart and the waist is narrow and the bottom of the booty is full. And this is more exaggerated by high waisted jeans. So I think it's kind of like fashion pushed this as well as the pendulum swung the other way and people disliked that
the shelf
exaggerated. Look. Exactly. And they saw too many, like, I don't know, rapper girls looking bad at the shelf look. And they're like, oh, I don't know about this. Or also time wise, right? So people started to get over time in the last 10 years, you have more people getting a round 2, round 3 booty. And if this isn't done to match the thighs and all this kind of stuff, now you got this big bubble butt that a lot of people don't like because it's exaggerated and it doesn't necessarily look like what normal humans look like. And it's fine if that person's happy with it. It's awesome. And it's impressive. Surgically, it's impressive in a lot of ways. But I think that a lot of people or a lot of patients have shied away from that because they just don't like that look. A lot of people, most people still don't want people to know necessarily they got work done. They just want to be like blessed with that booty. You know what I mean? Like, that girl's blessed and that booty's amazing. So that's like the shelf versus the slope talk. So I don't mind looking at wish pics. That's a whole, okay. So we'll get into that too, wish pics and stuff. So most surgeons maybe like wish pics, maybe not. I think wish pics in some ways are helpful because if you like a shelf or you like a slope, it helps me to kind of know, and we'll have a discussion about like, well, we're going to inject a little more here to give you that. We're going to inject a little less here to give you that. Now, if you are already coming in with a butt and you don't have like a super flat booty, if you already got some butt, now we're closer to a shelf, we're closer to a slope, and we can kind of play with that and we can play with that shape. I see a lot of patients, maybe half the patients who come see me, who have like no butt at all. And it is flat and it's from the back is going straight down, right? So in these people, they may show me a shape of a shelf or a slope. But more, I'm kind of like thinking about it surgically, meaning that like, listen, whether you like this shape or not, we got to put in as much fat in all areas of the butt as your butt's going to take because we need to create something before we even create much of a shape. You know, like these are girls who are almost certainly going to need 2 rounds to get to that kind of a round butt or something like that. So it's like, if you come in with a super flat butt, you got no butt at all, and you want to have like either a bubble butt or a round or a round butt or a shelf or a slope, it doesn't matter. We just got to put in as much fat because we got to build any kind of a base. You're coming in with nothing. So we got to build something before we even start going towards a slope. So because like, say if I try to create a slope in someone who's got like no butt at all, it means that I have to inject less at the top of the butt. And then after surgery, there's really not going to be much difference at the top of the butt at all. It's still going to kind of just go flat down. It's just not going to look as good. It's like we need to build up that booty before. And the other thing that I found is that it used to be maybe 5 years ago or so that 10%, I would say that maybe 10% of girls would go for a round 2 BBL. And now I think it's more like 1 out of 3 girls is going to want a round 2 BBL. And I think that that's because, our techniques have gotten better. So I don't think the surgery has gotten worse. Like we're better at creating shapes. We're better at, so VASER helps you to like have better fat take in the butt, for instance, so that's awesome. So technology has helped to improve our techniques and our surgery has gotten better. We do high def and all this stuff. So surgery has gotten better. I think what has happened is people look at Instagram. I think people with larger butts and kind of shapelier butts are more normalized, and people's goals, I see more goals of like girls that I'm looking at, like, I'm like, this is a round 2 booty, or there's a whole lot of Photoshop going on. Mm-hmm. And I'm not seeing as much like back in the day, you'd be like, oh, I want a J-Lo butt. And J-Lo's got like a nice, cute butt that you would get in the gym. And now it's like, I can't even deliver a J-Lo butt to anybody. Nobody's going to have you with a J-Lo butt. They want like double, triple J-Lo butt.
And you know what? I've said it in a few episodes before. You guys, you want to look good in person. Does not matter. Like you can exaggerate your posing and everything for pictures, but just remember, you want to look proportionate and normal in person. And forget what the Instagram pictures are. Forget, how big you can make your hips look for these pictures, because you can wear an extra garment and freaking do some waist training. But remember, you want to look good in person, normal.
Yeah.
Not just for Instagram, not just for your pictures, not just for online. Like you want to look normal. I would hope so. You would want to look normal. Just don't. I've seen some triple XL BBLs that I'm like, how is that going to age?
Yeah, it's not. Yeah, it's going to be hard for it to age because like, once the sagging kicks in and the things start to go down, it's tough. It's hard to fix it as a surgeon sometimes because you think that, you just go in and like reduce the butt or lipo it down, which you can in some people. But like, once that butt is like 3 times the size of the thigh and it's not matching, like you can't inject that much in the thigh to match it up to the butt. And you're like, now we're like, we need a couple rounds. Like, let's get this booty much, much smaller. Let's get this thigh up. And I think the other thing that happens with that is that, so I'm big on following a lot of the natural curves of the body. This gets into hips and lats talk. So I like to kind of follow the curves of the body, expand your hip where your actual hip is, and not try to create a higher hip where your body is not letting us create a higher hip because your hip bones aren't there, because it's going to look weird. And when people look at it, it's just going to look weird. So I'm big on transition injecting down to the thigh. So I inject the butt, I inject the hip, I transition inject down to the thigh. So all these things are kind of looking good. Now, an old school way of, exactly. Yeah. So they're all matching, right? So you look good from multiple angles, not just like from the front, from the side, from the back. Like I like that 3/4 angle, which is like, you're kind of seeing the belly, you're seeing the hip, you're seeing the thigh and all that and the butt, and it all kind of flows, right? And it all matches. And that looks good, I think, in my opinion, aesthetically to the human eye, because we like matching stuff and flowing type stuff and not exaggerated stuff necessarily. I think what happens is BBL surgeons who are maybe more amateur or more of an old school way of thought is just inject the butt, just put as much in the butt as it'll go. And then what happens is someone gets a round 1 from someone who will just inject the butt, not the thigh. And they get a round 2 from someone who just injected the butt. And then they come see me and I'm like, this butt is just super, super injected and these thighs haven't caught up. And it's like, dude, we're going to have a hard time like reducing this butt and then injecting the thigh and trying to get all this stuff to match up. And then also the girls, it's hard to get that to match because now they don't have as much fat to work with around their whole midsection and thighs and all this kind of stuff. We don't have as much source fat. And then also they've gotten used to that bigger butt. And they actually kind of like that bigger butt and they just want the thighs to match. But it's really hard to get that back in line once we've gone down that road a couple rounds,
Yep, it really is. What about this hips and lats talk?
All right. Yeah. So I saw this starting to pop up, I don't know, like 6 to 8 months ago. And I was like, oh, dude, or like a year ago. And I was like, oh man, this is going to be a whole, it's going to add so much confusion to the whole thing because it's not like super clear. So hips and lats, what my impression of hips and lats are, and from all the photos that I've seen this mat. So your hips are basically, if you feel your hip dips, right? So like if you feel right in the middle of your hip dips and you went outward, that is where your hip should be. And really, it's actually, if you look at your butt crease, if you literally look at your butt crack, from the top of the butt crack to the bottom butt crack, in the middle of that, if you draw a line outward from the middle of your butt crack, outward to the sides, that's where a natural hip should be on everybody's body. Okay. Now, that is what we would call hips. All right. So that should be the widest part. What lats are in some people, because they have high hip bones or the way that their hips are, it's a higher hip. And so that hip almost goes up to the waist, right? So your most narrow area should be where your belly button is, right? So right where your belly button is, that should be the narrowest area. That's where we're trying to get that snatch, just trying to narrow it. And people who have lats, that curve starts all the way up to where that waist is. So it's basically like a higher hip, okay? So hips versus lats. Hips are low, lats are high. The problem with trying to create lats in someone whose body becomes more of a hip is that in order to create lats in someone whose body needs more of a hip, you need to leave more fat in the love handle area. So it's basically like this curve from the hip going up to the love handle area, going up to the waist. That is what a lat is. So why do I not like to do that? Because listen, when you're coming in for lipo, you don't want me leaving love handle fat.
Heck, all right? No,
not at all. And if we're trying to create that on your body to kind of artificially create a lat or like a high hip, it's just, I don't want to say it's impossible. It's just like really, really super hard to nail that and have you not looking chubby in the love handle. Like you literally have to leave love handle fat. And part of the secret of rounding out the butt, so part of when someone gets a lipo 360 and their butt looks better and their hips look better, it's because you got to lipo them down lower than the lat. You got to lipo them down lower than the hip bone. You got to go really low on that side and take all that love handle fat that goes all the way down to like their hip dip, basically. All right. And that's kind of like one of the secrets of how to make a butt look better when you're just doing lipo 360. So if we're doing that, if we're taking all that love handle fat, which is literally what you want me to do, you want me to snatch all the love handle fat, what you're paying me for. Don't make me try to leave you some in the lat area because it's just really hard to make it look good. And I'm just having to leave love handle fat. And it's more likely that we're not creating lats. It's more like, oh, we got to leave love handle fat. You're going to be like, oh, what's this?
What's this right here?
Yeah. and that's usually what happens. Yeah.
And remember, you guys, I was just talking to y'all about the very slippery slope of weight gain after surgery. So those fat cells that are left there will plump up.
Yeah. And it's like,
remember,
no, it's true. I'm sorry to interrupt, Navi. No, you're totally right. And it's like, I've had girls, so people will come and show me my own patients' photos. And I always try to create hips. I always just try to create hips where the hips should be. That's one of those things I'm like, I'm just putting these where your body says that your body should be its widest, which is kind of in this hip dip area, just below your hip bone. Okay. Your pelvis, your upper pelvis bone. I've had people come in and be like, oh my God, I love this girl's look and her lats. And I'm like, well, I gave that girl hips. It's just, they look like lats on her. So ultimately that just comes back down to, we should follow the lines of the body. And if your body is more set up for a lat, then when we do this augmentation and following the curves of your body, you're going to look more like lats. And part of the lats look, if you look at girls in these photos from the front and you're seeing what you think is lats, it's actually like the upper side of the butt. It's almost like you can see the top of the butt from the side, and the waist is so narrow. So it kind of gives the illusion that there's a higher butt hip thing, but it's really like the top of the butt that you're seeing from the back. So there's a little bit more complexity in that thing. And I think it just means that like, don't try to create it artificially, because whenever we try to create things artificially around the body, they look weird to the eye, because over thousands of years of evolution, our eyes have been, our brains have developed in a way that we need to know what's natural and what's not natural, so that what's aesthetically pleasing and not. And if you start trying to create certain things that don't fit your body, it's just going to look weird. Even if you get that one Instagram photo that looked like you got less, you may look weird in all the other photos because you couldn't, you didn't nail the look.
We couldn't position you properly for that picture.
Mm-hmm. Mm-hmm.
Which I think really a lot of it is pictures. They're enhanced pictures online that have been edited or photoshopped.
Yeah.
And we're trying to achieve these, this tiny, tiny, tiny waist and these big old hips that realistically, you guys, that probably doesn't happen in nature very often. Another thing is a lot of those pictures that we're seeing, and not just for you but for most surgeons, they're not going to post, the picture where it was not a home run. They're posting their home runs. All surgeons, I myself, if I was a surgeon, I would be posting my home runs, and I would not post, somewhere where I'm like, man, I could have done a little bit more here. I could have done something different. So you're bringing your wish pics from another surgeon are their best, or they're very, very proud of these cases. Right. And
yeah, I think you want to see consistency too, right? Like
consistency. Yeah.
Yeah. If you see a surgeon putting out a consistent good result or a consistent good shape, I think you look into their like philosophy. If you see surgeons talking about what are they doing, so like Dr. William in Miami, whether you like him or don't, he talks a lot about his philosophy of how he does his like OG BBL. Dr. Jung in Houston, I think it's incredible results. I love his results. And he talks a lot about his philosophy. I usually talk about my philosophy a good amount online too. I think Gavami in California. So all these surgeons' philosophy is different. All their results are usually consistent in a certain way. And that's another thing is like, if you like an exaggerated look versus like a natural look, you should go to the surgeon that you vibe with. You like their philosophy, you like their results consistently, and they have perhaps bodies that look like yours, right? So some people are better with bigger bodies. Some people are better with smaller bodies, or it's kind of like, you wouldn't go to like the Mercedes dealership, the Maybach dealership and ask for a Ferrari. It's just like different, right?
Exactly.
So it's like, if you're looking for a Ferrari, just go to the Ferrari dealership, because that place is putting out Ferraris. Now they're putting out different models of Ferraris. All the Ferraris look a little bit different because they're all just different purposes and whatnot, but they're all slick looking Ferraris, And it's like, if you like a BMW, you just go get a BMW, and you're not looking at Ferraris because it's just a different type of car, Exactly.
So that's why I always recommend you guys see 3 surgeons, 3 different style surgeons. You just have to get to know, get to vibe, get to see like, hey, maybe I like these results better, or I vibe with this doctor and I vibe with his results, and this is a good match.
Yeah. I mean, it's like, I tell patients the same thing about the 3 consults. Like, if you get your kitchen remodeled, they tell you to get 3 quotes. And that's just for your kitchen, let alone if it's your body.
Exactly.
And it's like, I don't think, I have no problem with my patients seeing other people. If they vibe with someone else, they vibe with me. It's all good. I think as a surgeon, like, you shouldn't be afraid. I mean, like, why would you be afraid that someone would see somebody else? Like, you should have pride in your work and know that, like, look, if this person likes my work and they like what I tell them, the safety, and we have a vibe, then they're going to go with me, and that's cool. And if it doesn't work, it's like a relationship. Like, it wasn't meant to be. And I always tell patients, like, it's a team approach. And you know this, Mavi, you were in this.
Absolutely.
Like, you're in it for 6 months. You know what I mean? So it's like, we're in it for 6 months. I can't do it without them. They can't do it without me. we're in it together. So like we better vibe, they better kind of understand my philosophy, and I'm trying to understand what they want out of surgery, because we're trying to get to that point 6 months from now, you know?
Something that I touch on my Instagram, and I feel, you know, needs to be a little more out there, because I personally have had to talk to patients where I'm like, you have unrealistic expectations. And I don't think anybody can deliver what you're looking for. So whenever you're in a consultation, do you have red flags? Like when you're talking to a patient that maybe things that they're saying that you're like, okay, this patient's not going to be happy with my work, or maybe I shouldn't take her on. You know, I want our girls to know, hey, just because you're going doesn't mean he's going to take you. If you're crazy, if you have unrealistic expectations, I don't expect this, you know, any surgeon to touch you. So
yeah. And it's like, it comes down to, can we deliver a happy patient? You know what I mean? Something that like, can we deliver something that the patient's going to be happy with? And if the patient is like super critical, and there's different ways to look at this. So yeah, if you get that vibe that the patient is really tough to make happy, then we don't necessarily want to take on the case, because it's not fair to the patient. I'm more like, look, if I don't think I can deliver that result for the patient, it's not fair for me to take their money, take them through surgery risk, take them through recovery, only to be like, oh, 6 months later, I'd be like, well, you know, I didn't think I could actually deliver that for you. So like, I shouldn't have taken on your case. It's not fair, right? So one of the things that we look out for is when someone comes in and they're complaining about something. Let's say they're complaining about their nose, right? They're not even talking about BBLs. So talk about their nose. Let's say the actual deformity and their complaint, if it's out of proportion, that's a red flag. So if someone comes in and they got a cute nose and they're telling you something like, I hate my nose. I can't even be seen in public. I'm so embarrassed. I hate taking photos. And you're looking at the nose like, dude, this is a pretty good nose, not even that bad. Then you know that's a red flag, because perhaps it's not the nose that's bothering that patient. There's something else there. You know, now if a patient comes in and they're like, I hate my nose, and their nose is like huge and it's like a real, like, doesn't look good, you're like, okay, this complaint is in line with the deformity, so to speak. All right. So that is someone that you can potentially make happy. Now, I've seen girls where they are super skinny and they'll come in and they're grabbing their skin on their side of their waist and they're like, I hate this or I hate this. And I'm like, look, surgery is not going to make things any better here. Like, I could lipo the heck out of you and it's not going to look any better because I can't remove like your ribs or your muscles. I don't recommend that. There's actually people removing ribs now and it's like extreme. And I'm like, I don't recommend it.
You're kidding me. You're kidding me.
No, I'll tell you, Dr. Epley in Indiana. And what's funny is that like, it's really extreme. He does a lot of crazy, like good work, but I think he does a lot of like kind of more extreme stuff. I mean, the guy is obviously talented and surgically really good, but I personally do not think we should be removing ribs. It's just, I think that's too extreme.
I thought that was a myth. I thought it was a myth.
I thought so too. I know. But if you check him out, like I was like, oh my God, this is actually happening. So, but I tell patients like, look, I can't remove your ribs. I can't remove your muscles. This is your skeletal frame. So one of the red flags is if they're coming in and they're grabbing stuff that you cannot improve with surgery, you can lipo the heck out of them and it's not going to change, then that's a red flag. If the other thing is people come in and if they bring in a lot of photos that are like clearly photoshopped or these girls look way different. And I'm thinking, this may take 2 rounds of big surgery and I may not even get you there, then that's also not fair to like be like, look, you're going to have to put up this money twice and get you through recovery twice. And I don't even think I can get you there. That's tough. You know, there are some things that I don't think that I can fix. So I think cellulite is a very tough thing, right? So cellulite is something that 90% of women have. And some people have it mild and medium, and some people have it really tough. And everyone who comes in with a tight butt with tight cellulite is really hard to expand on the table. It's like these tethering ligaments that are just pulling everything down. And I had little tools and tricks that I use to try to expand that, but there's no cures out there for it, which is annoying, But these are patients who they come in and I can't blame them. They want a round butt and they want a juicy butt, and you can see they really want it and they deserve it. Who doesn't deserve to be happy? Who doesn't deserve to be happy with their body? But they have like this really tight, severe cellulite butt that I just know that with all the tools and tricks that I know that are out there that I can do, I can't get this thing rounded and expanded. And even with 2 rounds, I don't think I can do it. So that's tough because I see the desire and like the look in their eyes, like they're really hoping that you could tell them you're going to fix it. And I just don't think I can because it's just, there's nothing to do that I can do about it. Then it's a hard discussion and I need to tell them like, look, I just don't think I can do this. And it's not fair for me to take on your case if I don't think that I can deliver a stellar result for you. So those are kind of things
I love that. I think it's very admirable when a surgeon can be honest with their patient and tell them this, I might not be able to get this for you. Mm-hmm. I think it builds that trust, you know, and I always talk to you guys that you need to build a trust with your surgeon because recovery is hard. Surgery recovery is difficult. And if you don't trust your surgeon when he's telling you this is just swelling or this bruise is going to go away or, you know, this is normal. If you don't trust him, you're not going to believe him. You're going to feel uneasy during your recovery. But if you trust your surgeon and you understand his or her philosophy and you understand the recovery, you're going to be like, hey, my doctor said this is normal. It's going to be fine. I'm going to work through it. Swelling's normal. Mm-hmm. Bruising is normal. So this is very important in building that trust with your surgeon. Yeah.
And it's a lot easier. It's easier to have that difficult discussion of having to let down a patient or a patient being let down after our first consultation rather than doing that surgery and 6 months later being like, oh, sorry, it can't be fixed. You know, like it's like breaking up with someone after the first date versus like 10 dates. If you knew from the first date that like, oh, I wasn't even really feeling this person, you know?
That's a perfect analogy right there. Yes. Don't waste.
You're just trying to, you're not trying to waste people's time. And look, I'm only one surgeon and maybe some other surgeon, you know, they should still, I tell them like, you still get other consults. If you hear 3 surgeons telling you the same thing, like they can't do it, then that should tell you something, right? Mm-hmm. And sometimes that's like 3 surgeons telling you it's unsafe for you to have surgery because you have this heart issue and it's a freaking thing that we need to think about. Or it's sometimes 3 people telling you like, oh, there's not that much fat to take, or this butt can't be improved that much or something. If you hear 3 people telling you, then that you should listen to that. And perhaps you shouldn't keep looking for a surgeon because you'll always find a surgeon. You keep knocking around. You're going to find someone who took a weekend course who thinks that they can give you that look. You'll find someone who'll take your money and try to give you that look, you know? So it's worth listening to a couple of people. Now, if they come to me and they hear something like I can't help them, but they go to somebody else and they tell them that they can, then that's awesome. They probably just found their surgeon who can actually deliver perhaps that result for them. But it's not fair for me to take on that case if I don't feel like I can give them that result, you know, to make them happy.
Okay. Yeah. So now we know some red flags. Let's talk about chicken butt.
Oh man. We're talking about all the terms online. Like this is the pros and cons of Instagram and like online. The pros are you can get more educated. The cons are we got all these terms now that are just like can be very confusing. Now, one thing that is not super confusing is chicken butt. And I remember, I think hearing about this or seeing this online, maybe 6 or 7 months ago. Okay. And I was like, oh Lord, here's another term. And I felt bad because like this term chicken butt refers to kind of like the lower inner part of the butt that if you look at a chicken, it basically kind of swoops up and then divots down again. And it's just kind of like this. If you look at a few pictures, you'll understand what I'm talking about. It's basically this certain kind of like divot or waviness at the bottom of the butt, on the inside part of the butt, like down and inner, that looks kind of like a chicken, right? And I wish I had a better term for it because I see a lot of girls like this and I'm like, oh, I don't even want to say it, but girl, you got a chicken butt. You know, it's like, it looks like this. And the thing is that most of these girls have usually heard about this online. I'm like, have you heard, I'm sorry to say this, have you heard about something called a chicken butt? And they're like, yes, I have. And I was like, I think you have an element of this. So I say it in a much more nicer way. And I can't wait until there's a better term for it. But so, like I said, this is the certain kind of shape to the inside of the butt. And if you go online, you'll hear about different shapes of the butt. There's like A-shaped, there's V-shaped butts, and these have certain challenges in surgery. Like a V-shaped butt has this lower outer area below the hip that's really hard to expand, and like you almost certainly need 2 rounds to expand it. So these certain shapes that you start with, or like asymmetries that you start with, or certain, if you're behind the 8 ball in such a way, before the first surgery, you might need 2 surgeries to round this out. So chicken butt, if you look at the pictures, you'll see what I'm talking about. It's kind of like this W shape at the bottom of the butt. I've been working on a way to kind of make this better. And I've taken on, like, I do see some patients with chicken butt and I tell them like, look, this is not really going to get rounded. And I was talking about this earlier. Everyone always wants what they don't have. The grass is always greener. People who come in with a super flat butt, like really want a round butt. People come in with a chicken butt, they really want a round butt down there. Like they always want like that area to be fixed, which I totally understand. But like I said, if we don't have like good surgical ways to do it, I got to be honest with patients about that. Right. Mm-hmm. So I've been kind of working on this technique and to kind of inject in such a way that what you don't want to do, and people will be like, well, how do you fix it? In my opinion, The exaggerated portion is the part that, like, if you think about your butt like a clock, and you're talking about the 6 o'clock portion, right where it's 6 o'clock is where your butt sits downward and sticks out. And then kind of where like 7 o'clock and 5 o'clock is where it dips, it goes back up again, and then it kind of curves. So the problem is that you have a dipped down portion at 6 o'clock, and then it goes up right next door, and then it kind of goes around. So you don't want to, and what I've seen is exaggerated chicken butts that get worse because I think amateur surgeons will just inject everything maximally. I think you have to totally stay away from the portion that's 6 o'clock and dip downward, and you have to really inject a lot in that 5, 7 o'clock portion next door that to get it to expand. That basically has a volume deficit that you need to get more fat in there. And in a decent amount of these cases, I've been able to get a straight butt. Okay, so not rounded, but like kind of straight across, meaning that it looks normal, but it doesn't look like round, but it gets normal. And it's kind of one of the things where, like, if you come in with a super tight hip dip, with one round, we may get you to just a straight hip. And then with the second round, we'll get you to an hourglass, and sometimes we overshoot. I always try to be conservative in what I tell patients before surgery. I try to like under promise and over deliver, and I try to be very honest. Yeah. And I try to be very honest. So like, look, this may take 2 rounds, man. Most likely I'm going to try to do everything I can on one round, but it may take 2 rounds, or it will likely take 2 rounds, or it will likely take 2 rounds. And I think we can't even get you to these wish picks because this girl is 22 years old, the different skeletal frame and no kids. And, you're, 50 years old and you've had 3 children, and it's just like a totally different like skeletal frame or something like that. So there's just different starting points, which means that also different ending points. Like there's only limits of how we can't change that skeletal frame, right? So with the chicken butt, that's what it is. There's not a lot of surgeons that I've seen online who are like doing certain things for it to make it better. And this is a technique that I've found that actually it's been helping, but like at best I can get it straight in one round, and maybe the second round we can get it rounded. But I think even getting it straight is a bit of a win because like it just doesn't look like a chicken butt anymore, and it just kind of gets rounded. Now, there's something out there called a thong lift, which I heard about in the last year that I think one of the guys in Florida does. I can't remember who does it. I think a couple of people do it. I don't think it's like the end all be all. Basically what it is, a thong lift, is like excising an elliptical portion of skin from like really the inner side of the butt. And I'm talking about like kind of about the lower butt crack and that 6 o'clock portion where we talked about. And it's a decent sized scar and it's on the inside. And yes, you can do that and then tuck in that chicken butt and make it a little bit more rounder. And it can look good from that certain angle, but you are going to have a scar underneath. I personally don't like putting a scar in there because it's kind of like thigh-plasties and thigh scars where like you're just going to get stretching of that scar because that area wants to move. It's by your leg. It's really close to kind of like the anus. So you worry about bacteria and infection in that area too. So I don't think the thong lift is like the end all be all because it's like a scar that removes skin and it helps and blah, blah, but I don't think it's like the end all be all to this. So that's what chicken butt is. That's, I think, where we're at with fixing things. And I think because it's been talked about in the last year or so, we're seeing more of it, just, kind of as patients come in and they complain about it, and we're working on ways to make it better. So
to add to that, you guys, chicken butt is not being created by your garment. It is not being, made by the holes that are in your faja. Whoever told you that
100%
was not being truthful. That is not what's happening. That was already there.
Yeah, I agree. And that I saw people starting to talk about that, I don't know, 6 months ago or so. And I was like, oh Lord, this is not even a thing. The chicken butt is kind of like a very severe cellulite in that very specific area. And it's like, you're not getting cellulite from your garment and you're not getting chicken butt from your garment either. It's just these underlying ligaments and kind of soft tissue tethering of the skin deeper, So I agree. I don't think it's being caused at all by the garment. It can be exaggerated because like sometimes your swelling goes downward and it kind of expands in that lower area where it's like swelling and it expands in that lower area where like the garment is open. But I don't think the garment is causing that at all. It's just because that swelling goes away.
Perfect way to end that. So it's not the garment. There's ways that we can try to make it look at least even. At least even, maybe not round, but we're working on it. There's doctors like Dr. Azizi out there trying to figure out how to make it better.
Yeah. And we'll get it, like I've gotten patients round in one round, but like, I'm not going to tell you that. Like, I'm going to tell you like, look, if we can get it straight, that's a win, and sometimes you get in surgery and you expand things out and you're like, oh man, things get easier. Sometimes you get in surgery and things actually move easier than you think they will. Not often, but sometimes they do. But it's better to go into surgery being more conservative with your expectations, because if you're always expecting the moon, you're never going to get the moon, like, but if you're thinking like, hey man, if I was flying in the sky, I'd be happy. And like every once in a while I get to the moon, like awesome. That's a good way to think about things too.
I love it. Okay. So let's move on to this next topic that I think is just a little controversial, and I like it because a lot of surgeons won't do it, but a lot of surgeons will. So combo surgery. Combo meaning like tummy tuck, BBL at the same time, or multiple procedures at the same time.
Yeah. So what's the thing about with combo surgery? So some combo surgery, some surgeries combine really well. They're very complementary. So like a breast dog and tummy tuck, but your classic mommy makeover is a very complementary surgery, because like the recovery is complemented by two of these things, and it's done pretty well and easily in surgery. One thing to think about. So the first thing to think about with combo surgeries is that we usually don't want you on the table for more than 6 hours. So that's the first thing, because more than 6 hours tends to increase the chances of infection and blood clots, because blood's just not moving as much. It's just a longer surgery. Recovery is harder. I find that like after 6 hours, patients have to be admitted to the hospital overnight or something like that. So when we're doing elective surgery, I like people being outpatient going home, because there's less bad bacteria at your house than there is at the hospital. There's more chance of you getting up and move around your house and preventing blood clots rather than sitting in a hospital bed, right? So like 6 hours is what we're trying to keep all our combo surgeries to. Okay. So then you got to think about like, well, how many surgeries can we get into that 6 hours, and what can we combine nicely? So the big talk now is BBL tummy tuck. All right. And the big reason we talk about BBL tummy tuck is because positioning in these things is like different in both of them. When we do a tummy tuck, we usually want you on your back because we don't want pressure on the belly. And when we do a BBL, we want you on your belly because we don't want pressure on your butt and your hips, right? So what do you do afterwards? And Mavi, I've heard you talk about this. And I tell patients usually, so when we do a BBL tummy tuck, and I've gone back and forth on this topic, in certain people, a BBL tummy tuck works well. I think girls who are a little bit bigger, who like have really bad skin in the belly and they need a tummy tuck, you should get a tummy tuck at the beginning regardless. Whether you're combining with a BBL or not, like you got to get a tummy tuck at the beginning, because otherwise your skin's going to be hanging for 6 months until we do that tummy tuck. And it's just better that way. You're just going to get a better result. You can always come back and refine that result with the BBL 6 months later. So that's kind of the first discussion. People have to think about like, well, do I want to two-stage it? Do I want to do it together? If someone is skinny and we need all the fat that we can get, a BBL tummy tuck is a good thing for those people, because we can lipo that belly fat, belly skin at the bottom. And then, we're going to toss it anyway, so we can use it for the butt. Positioning is like the big thing that we talk about then. So I like patients. So with the first thing I'll say is that patients always figure out what to do, right, Mavi? Don't you guys just figure out, first of all, how to position yourself that's like comfortable? And like the girls are like amazing because they freaking figure it out. Like even if I can't tell them anything, they're like, it's cool. I found like this
pillow.
This weird pillow from like Saigon, and like it's fitting me perfectly,
So for me, the way I did it, I slept like a queen. I had a pillow under each arm, a pillow under my lower back, a pillow under my knees, a thick pillow. So I was still kind of bent forward, but my butt was also kind of suspended. It was the whole weight of my body was not on my booty.
Yeah, I agree. Fine. I think pillows are key because it's all comes down to pressure points, and the more pillows you have around you, the pressure is lessened. And so you're not putting as much direct pressure on things. So when I do like a BBL breast dog, I will allow the patient to lay on their belly with a big fluffy pillow under their breast, because it's just cushioning the breast and it's not really putting much pressure on the breast. So when I do a BBL tummy tuck, I usually want patients leaning forward. I like them having a big fluffy body pillow and kind of hug up on that pillow, lean forward. That way your butt's a little in the air. You're not putting direct pressure on your hips, and you're not really putting direct pressure on your tummy either. Okay. And so I think it is doable. Sometimes we have to think about if someone is a higher BMI and we need to take out a lot more fat on them, maybe we need to do one big old lipo session first and then do the tummy tuck later, kind of hit them with 2 big rounds of lipo to get them snatched and looking good. So then we can't do the combo, but I think in general, BBL tummy tuck combo is safe. I think the hardest part about it is positioning afterwards. You do have to think about recovery. So I usually tell my patients that you need minimum 2 weeks recovery for BBL. You need minimum 2 weeks recovery for tummy tuck. And if you combine surgeries, your recovery is usually going to be harder and longer, maybe by a week or so. So for BBL tummy tuck combo, I tell patients, like, you probably need 3 weeks at least for that. And if you take more time, then that's awesome. You should. Interestingly enough, combo surgeries, when you add breast surgeries onto other stuff, it's not as bad. So I think if you have to rank what are the toughest surgeries for people to recover from, I think tummy tuck is probably the toughest surgery for people to recover from. Then a BBL, then like any breast surgery. So usually when you're getting combo surgery,
I've had all of them.
there you go. There you go. So it's like, no, I'm not breaking any new ground here with saying this, But like, I find that when people are combining, you're usually recovering the most hard one first. Your focus of your recovery is more on your tummy tuck. If you do like breasts, people are almost like breasts are an afterthought. You're almost like, what breast?
You forget.
What surgery on
you
the
almost
breast?
forget.
Yeah. I got to the point where on occasion with certain patients, like when you're feeling a patient out in that consult, and if you feel like a patient is really distracted and you can't tell them certain things or not paying attention, and you know that this patient's not going to pay attention to you later. I had patients where they couldn't focus on healing two things, like the breast and the tummy tuck. Like I couldn't get a breast dog tummy tuck sometimes to heal properly because I would tell them like, look, watch out for this abdominal binder, for instance. Don't let it rub up on your breast. And they'd be like, okay, cool. And then I'd see them a week later and their breast incisions are like falling apart because they've like just let that thing right up on them because they can't concentrate on two things, So sometimes I'm also feeling it out with the patient to be like, can this patient handle these two surgeries? And I also ask about life situation. If they got like 4 kids under the age of 5 at home, that is way different than if they got 2 kids that are fully grown.
Yeah,
if they're telling me like, oh yeah, my sister's a nurse, she's going to hang out with me. Oh, I got family in Chicago, someone's coming in from out of town. They're like, I got family in Chicago I'm going to stay with. That's a different thing. And so it's not in a vacuum to do a combo surgery. Like I worry a little bit more when people are getting bigger surgeries and they have like multiple young children at the house, unless I see someone like who's like maybe their husband's there or their wife is there and they're like helping them with kids or something. And like, or they have like their mom is there with them at the consult, So it's not within a vacuum. So when you do a combo surgery and a bigger surgery, it's going to take you a little bit longer to recover. So you got to make sure that your life situation is good when it comes to like kids or work or taking time off and that kind of stuff. And it's like, if it's not really there, it may be easier for you to break it up into 2 surgeries and peel off 2 easier recoveries, 6 months separated rather than one bigger one, even though everybody wants everything all at once. You want to go to like, you want to go to the restaurant, you want to order everything at the nice restaurant all at once, but sometimes you can't, you're going to be too full afterwards. You can't handle it,
Sometimes. And it's good to be able to have that judgment. Like, hey, maybe this might be too much of a recovery for me for what I can handle right now. And that's fine.
Yeah.
And that's why I talk to our listeners, to my girls. I'm like, we have to plan. It's not you plan accordingly. You give yourself time. You can arrange all of the things to give yourself an easy recovery. Then, try to do it, set it up. I want to have surgery in 2 months. Let me try to figure it out.
Yeah. And like, then recovery is less traumatic, right? Like if your life is right when you're getting that recovery, then it's like, maybe it's not as bad. If your life is really hard when you're getting that recovery, like it's going to be a traumatic experience. And I like to do, like, if I'm going to do a surgery, I usually like to do the one at the harder recovery first, because usually that's involved with like the bigger change on the body, right? So like if a patient's getting a BBL, we're operating on like half that person's body. So the recovery is like somewhat hard, right? Or like medium to higher recovery. So do that first. And then if you want the breast implants or a breast lift or something, and if you can't handle all these things at the same time, well, we do the breast lift like 3 months later. And that's going to be like an easy recovery because you just went through like a tougher one and you're a pro. And, you're going to be able to peel off that second one a lot easier then,
Absolutely. And it all boils down to planning.
True. Pros and cons. Yeah. And pros and cons, right? Like I totally agree. Sorry to interrupt, Mavi. I'm sorry.
Oh, it's okay. It's okay. How about you tell us I'm going to have you guide us on controlling anxiety before surgery. And we know all too well, our nerves get to us. Dr. Google knows everything.
Yep. And you're going to drive yourself crazy. Okay. So I think in general, it's good to do as much research as you can before you go to your consults, right? So like go online, hit the forums, just like if you're going to buy a car, right? Like you want to go read up on it. You want to look around, ask other people, maybe they have that car, right? So you go on the forums, go on Google to read Real Self reviews. I think Real Self is really good. I think reading the reviews on someone is really helpful. Looking at pictures of recovery of people, that prospective surgeon that you're thinking about is really helpful. So you go on, you read everything, you follow that surgeon, all this kind of stuff. so that you're ready. Get your list of questions before you go to the surgeon. It's helpful. Like write them down, your 10 questions, whatever, so you can go through them all. So then when you go meet your surgeon, I think at this point, every surgeon does things differently. So like if you have 3 top BBL surgeons, they probably do things 80% the same and 20% is going to be different. And you got to listen to that 20%, right? So when you go meet your surgeon, then you absorb what they have to say as far as recovery and their protocol and everything. And this could be different, like compression garment stuff. This could be different massage stuff. This could be different sitting on the butt type stuff. And so once you go and you hear from them, you got to then follow, you got to pick your surgeon, and then you just ask those guys for their, you ask them the question of like how you're going to recover afterwards. I think the problem comes when people research a lot, go meet the surgeon, say me, for instance, and we're going to do surgery. And in the meantime, between when they've met me and we do surgery, they've gone back to Google and started reading everything. And they're like, oh, but what about this? Or what about this? And I'm like, listen, none of that stuff is relevant to your case at all. Like those girls look different. Those girls had a different body. We're not even doing that kind of thing on you. And so once you meet your surgeon, you come up with a plan, you should then be able to get a hold of your surgeon, ask them questions.
Or your coordinator.
Or your coordinator. Exactly. Either way. Or that office, right? You got to be able to, if you're, you got to be able to get a hold of somebody there at that office.
That's why I tell you guys, it is so important. I'm putting together a consultation checklist for them to kind of check off when they're doing their consultations. And one of the things that is very important to me is how easily can I get a hold of somebody and talk to a coordinator or a front desk or even my surgeon? How easy is it for me to communicate with the office? If I have to wait, a week to get a reply by email, I'm not happy with that. If I can't call and, hey, I'm having an emergency, I need to talk to somebody, I'm not happy.
Yeah, you got to be able to get a hold of them. I mean, like me personally, like people will Instagram message me all the time, and I get back to all my Instagram messages. Like I'm like literally anyone, patient, not a patient. If someone asks me a more complicated, longer question, it's going to take me longer to find time to get to them. But I try to get back to everybody within a day, 2-3 days, like max a week. If you literally ask me a consult online, but you got to be able to get a hold of that office. You got to get a good feel from it. If you don't have a good feel, that like, here's the thing. If you have a problem afterwards, you got to be able to get a hold of them and get in there. I've heard of like way too many stories of people ending up in the ER and like not being able to get a hold of their surgeon. And I'm like, dude, I could never imagine if that's my sister or my mom getting surgery, I could never imagine. That's just terrible,
doing that. So yeah, I agree.
Yeah. So you got to be, and it's true. And sometimes some offices have the coordinator who pretty much knows everything the surgeon's going to say, and they're the first line, and that's cool. And but you got to be able to get a hold of somebody. And it's like, if the coordinator doesn't know the answers, they'll kick it up to the surgeon. You got to be able to get a hold of them. So, but getting back to like the anxiety stuff, once you meet your surgeon, try to minimize your Google stuff, like leading up to surgery. I think preparing beforehand is always good. Like if you're, you want to do something, you're a busybody, and you're like, I just can't lay still and wait for your surgery. Getting your vitamins, getting your gauzes, getting your pads in case you have like oozing, foam, these kinds of things, I think is good. Like, because you got this, you're kind of putting that energy towards a positive outlet and having preparation, so that the more you got prepared, the more stuff sitting here. Maybe you got your meals prepared before surgery. You got your vitamin drinks, your water or whatever. Then after surgery, things are a little bit more cruise control, and I find that a lot of the anxiety goes away right after surgery. Like everyone's nervous leading up to surgery. Then we're on the flip side of once you get past surgery, you're just recovering. And I think a lot of people's anxiety, like 80-90% goes away. And now we're just focusing on day by day. Let's deal with the pain. Let's deal with the soreness, deal with the swelling, kind of go through this. So I think the biggest thing between when you meet your surgeon, you decide on them, and then you're going to go to get surgery with them. Don't hit up too much Google or forums and all this stuff, because it's going to kind of drive you crazy.
And it's going to confuse you. You'll end up more confused.
Exactly. Yeah. And that confusion is like, you don't know which way it's coming or going with the surgeries, So, yeah.
Okay. Yeah. So my last question, and then I will let you go because I know you're busy, but how about scar treatment? So I know a lot of our patients are very concerned about scars, hypertrophic scars, keloid scars, and scarring, period.
Yeah. So, okay. So first thing is prevention, right? So prevention in medicine, we always say prevention is better than treatment. So the first thing is, if I'm putting scars, so like with BBLs or lipo or tummy tuck, BBLs and lipo, I try to minimize the scars, and I try to always put them in hidden places as much as possible. I mean, I see some scars from other people that are just like freaking all over the place, like multiple scars on the back to do lipo. Like every little roll you got a scar for it. I'm like, this is terrible, dude. I can't stand that, because when you poke the skin, a scar is not going to disappear. You got to come to terms with the fact that like that, you're going to have a scar there, and you have to be able to wrap your head around that. And it's a trade-off. That scar is a trade-off. You know, a breast lift, you're trading the scar for the shape. When it comes to a tummy tuck, you're trading a low hidden scar along the bikini line for the shape of like what your belly is going to be like afterwards. So the first thing is, I think we always try to put scars, or hopefully you will find someone who's trying to minimize scars. I usually talk to patients about the scars specifically. I'm like, look, this is where the poke holes are going to be. This is where this is going to be. So that there's not a surprise. I'm not just like surprising people with scars. So number one, as a surgeon, I want to put things minimized and put them in places that they're going to be as hidden as possible, because you can't control how someone heals from a scar. And that really comes down to like genetics. And we can make it a little bit better with how we close the scar and with how we do scar treatment. But like genetics is a big part of it. And it's like a bell curve, meaning that like some people are on one side of it where they're going to scar incredibly. They're going to do no scar care. They're going to do nothing. They're going to eat Cheetos after surgery, and their scars are going to be like immaculate.
That's
right?
me.
And then, yeah, awesome. And you're blessed, and it's awesome. And like that, it's freaking great. And I wish everybody was like that, you know, but we don't know who's going to be like that before. On the other side, there's girls who will do everything right, and they'll still get a scar that's like what we call hypertrophic, which is a little bit thicker scar. Keloid is when like the scar really gets kind of bigger. So we don't usually see a lot of keloids. A lot of people think the hypertrophic scars or the wide scars, I think bad scars are all keloids. They're not. The keloids are a little bit more of a genetic thing. So just because, you know, you're African American doesn't necessarily mean you're going to get a keloid. Just because you had a bad scar in the past doesn't necessarily mean you're going to get a keloid. Now, previous scars in the same area of the body are a good indicator of what future scar is going to be. I mean, like a C-section scar is like a good indicator of perhaps what your tummy tuck scar is going to heal like, because it's same area of the body, same blood flow, similar tension, or a little bit more tension in the tummy tuck. That's a good indicator. If you had, let's say you had your gallbladder removed and you got these little poke holes around your belly, those might be similar to what your lipo scars are going to be like. They're kind of like poke holes. Now, when we're doing the surgery as a plastic surgeon, we're generally going to close these things better than like the gynecologist who did your C-section or the general surgeon who did your gallbladder surgery. So you're going to get a better closure with these scars because we just tend to care more about scars. So the first thing is prevention. Let's try to minimize it. Number two, knowing that what your previous scars are going to be kind of like what your future scars are. Now, if we see that you have hypertrophic scars or you have keloids, then we need to kind of keep this in mind. I usually like to see like, if someone's had surgery before, I like to see what their scars are like. So I can see like, oh, well, this is what the scar might be like in the future. If we know that you tend to have like hypertrophic or keloid type scars, then knowing that in the back of our mind, maybe when I see a patient around 1 month, I may hit that scar and if it's starting to get a little thick, I may hit it with a little bit of a steroid injection to try to get it to thin out. All right. And we have other things that we can do. Like on pretty much everybody, you'll always do silicone cream, maybe silicone tape and strips. And I'll talk about that in a second. But like we start silicone cream around a month, scar massage. Scars tend to get better over the course of a whole year. So you got a whole year of improvement that's going to be happening. I've moved away from doing silicone tape for my patients because I find a lot of patients have very sensitive skin. And I found that like way more patients, even though silicone tape and silicone strips theoretically has a better treatment of scars than silicone cream does, I found that like a third of my patients were getting like blistering under their like from their sensitive skin underneath those silicone tapes. And then the scars would end up worse. So I just moved away from doing that because you kind of have to wear those strips all the time. Sure, it's good for some people, but then a lot of people get the blistering and the scars end up worse. And then there's always, say you're 6 months out, you're 1 year out, you've done steroid injections, you've done scar care, the scar still isn't as good. And then we'll talk about like doing a scar revision, meaning that, okay, we're just going to, under local anesthesia, we'll numb up the scar, we're going to cut it out, and we're going to put it back together nice and pretty. That could then, I've seen that actually then heal good on that second round because when we're doing like a tummy tuck or like you say a breast lift with implants or something like that, there's more tension and pulling on that scar and that first surgery. And once everything's kind of stretched and settled and chilled out after 6 months, and if we just remove that scar and put it back together, there's less tension and pulling. So hopefully then that scar is going to be better and not pulled and not wider. And so these are kind of the kind of plan A, B, and C of what to do with scars. Worst case scenario, you got a legit keloid. The best treatment for keloids, and like you hit it with steroids and keeps coming back, is actually a treatment of low dose radiation. And maybe not a lot of people know this, but so you'll usually remove it. You'll remove the scar under local for the keloid. And then you get low dose radiation, like that day, the next day, and the third day. And the chances of the keloid coming back is only 20%. That's like the best treatment. So you got like 80% cure rate with the keloid at that point. So we do that for people like with earlobe keloids or like other random keloids that they may have. That's the best treatment. Not that everyone needs that, but sometimes like if it keeps coming back and you're seeing a plastic surgeon, then we need to kind of be all hands on deck with our treatment too.
That's right. And actually, I think a lot of women are more afraid of the keloid scars than they need to be. Like they think they're going to get a keloid or they think they're going to get a hypertrophic scar, when in reality, it's not as common as they think.
True. It's like, it's like 95% of women will be afraid of it, but only 5% of women will get it, So it's just, it's out of the proportion. And if you've had it before, yes, then you're a little bit more set up for it. And it's true, but more people are way more scared with it, And here's the other thing. A reason why I don't like to show scars on my Instagram or like show off scars necessarily on my Instagram is because like that random fact that you were talking about, like it's not fair for me to show all these beautiful scars of people who may scar really well and then like be like, oh my God, look at me, I'm a baller surgeon with my scars. When like it just isn't always in control of you. Now, belly button, I love showing my belly buttons and tummy tucks because I think I do them well. So I like to show that because that's a little bit different than just a scar, for instance. It's a little more of a technique thing. But that's why I think you'll find a lot of surgeons don't show scars because it's almost like ingenuine to show like all good scars because not everyone gets good scars. And so it's not fair for people to be like, oh man, this person always gets super baller scars. We're still dealing with the same population of humans that are all going to scar
heal differently. And I think, you guys, I know that the tummy tuck scar is probably the number one thing I hear of why people are afraid of having a tummy tuck. It's because of the scar. They're afraid the scar is too long or it's too wide. And when you go see a surgeon for your consultation, you can always ask them, correct me if I'm wrong, Dr. Azizi, that they can ask to show where is my scar going to be? And you guys, most of the time, we just want to look good in our clothes. And nobody's really going to see our scar unless you're choosing to show them your scar. So the scar, I mean, you get so much more than what you're losing with the tummy tuck scar. So don't be afraid of it.
It's true. It's a trade-off, It's like, well, you're not happy with that area anyway because you got that hanging skin. So it's like, well, now you're going to have a toned belly and you got a scar that's traded for the hanging skin. But it's like, well, you already weren't happy with that area. And yeah, you could definitely ask surgeons about scars. And usually we have photos of like previous scars that we could show you or like the placement. And I like to, if they ask me where the scar is going to be, it's different a little bit on everybody's body because everyone's body is a little bit different. Like I said, hip bones, the height of the vagina, for instance, and like where their like creases are and their skin issues, So sometimes if we need to do like a Mons lift, it may be a little bit different than someone who doesn't need a Mons lift. Or if someone's got a C-section, we're going to go lower than it. So there's a little bit different variability. Oh, the width of the scar. Usually the width of the scar. So a good way to tell like, well, how wide is my scar going to go? Because no one's ever worried about the middle of the scar. They're always worried about how wide it's going to be, like how far out. If you look in the mirror and you look at like, where is your skin folding over? And if you see your skin folding over, like over by your hip bone or like the side of your hip, or it's creeping all the way to your back, that scar is going to have to be wider. And usually the body tells us where that scar is going to have to be by where the skin starts to fold over. If you only got like skin folding over in the front of your belly, like narrower than where your hip bones are, then you probably don't need as wide of a scar. That's a kind of a one way you could look at the mirror and tell where your scar is going to be.
That's perfect. That's exactly right. Okay, Dr. Azizi, before we go, tell me if this were your best friend or your wife or your mom about to have surgery, what is one piece of advice that you would give her?
All right. So this is something that it's changed since before I was a plastic surgeon and now that I'm actually doing the work. The number one thing is, I think, do your research and get it done right the first time. And if that means you have to fly to New York to see that one surgeon in New York and it's more expensive and whatnot, when it comes to plastic surgery, it's your face, it's your body, it's your safety. Do it right the first time because it's hard to fix problems and it's hard to find someone that is going to want to be able to fix those problems afterwards. So it's better, and potentially it's going to cost you more. So pay a little bit more, perhaps, maybe fly to that one place, perhaps, get it done right the first time so that you're just kind of one and done and moving on.
Perfect. I definitely agree with that. And that's why it's so important to do your research. Make sure you're finding the right match with your surgeon. I tell y'all, it's like finding a relationship that you have to vibe with the whole, the office, the doctor, the results, the recovery protocol. All of that has to be in line with what you are looking for, and you get it right the first time.
Yep. It's all important. It's all that stuff is important for sure.
Thank you so much for that tip.
My pleasure.
So, Dr. Azizi, tell our listeners where they can find you, how they can reach you.
All right. So I guess the best way, I think, is my Instagram. And that is Dr. Azizi Chicago. And it's spelled DRAZIZI Chicago. That's where I put more of like my work. That's where I'm usually commenting more, and more of like my before and afters are, and kind of like everything is there. My website is ramplasticsurgery.com. So you can go there if you want to request a consult and get a little bit more general information. And they can always call the office at 312-337-3010. But between those three ways, you can usually get a hold of us pretty good.
That's perfect. What I wanted to hear was the phone number. Repeat it for them.
Sorry. 312-337-3010.
Okay, perfect. So
this is how you can tell things are different in 2021. Because if you ask the plastic surgeon this question 20 years ago, they'd give you the office phone. And now people are like, no, you got to go to my Instagram.
No, you gotta go look for me on Instagram. You can find me on my website. But I am more of an, I guess, old school, really. I like to call. Mm-hmm. I like to get on the phone and talk to somebody and ask 100 questions, and then feel good about who I'm talking to and what I'm talking about, and then be like, okay, I'm good. So you guys, you can call the office. You can find him on Instagram. You can go to his website. But Dr. Azizi in Chicago, that's who y'all just heard all of this amazing, really good, no sugarcoating information. And that's what we want.
Sometimes
want
I
no sugarcoating.
Perhaps I should sugarcoat it more sometimes, but this is the nitty gritty, man. And this is like, a lot of these topics are gray area and they're not like super clear. And so I just want to kind of talk about, what do we think of it from a plastic surgeon standpoint? What do patients kind of come in with as far as like their thoughts and everything? And so, hopefully it was helpful and a lot of good content for people. I think
you answered a lot of the questions that I want. You're a board certified plastic surgeon. And I feel like a lot of the information that's being thrown out there is not being thrown out there by qualified people or people who are qualified to speak on the subject. And that's why it's really important to me to bring people on the show who are qualified, who are in the know, and who can give the proper information without all the other confusion. Just give this is how it's supposed to be done. You don't inject fat below the muscle, no matter what you heard. You're not really supposed to be doing that. And that's what I want them to hear.
Yeah, I agree.
But for our listeners on today's episode, have I talked to you about Bruise Juice? I don't think I have. I
don't think so.
Bruise Juice is a balm that I formulated. It's arnica. It's just an extra strength arnica balm for bruising and swelling. I tell them to rub it on their booty, rub it on their tummy, and it just helps with their healing. I made a coupon code or a discount code for anybody who's listening to this episode. It's just Dr. Azizi, Dr. Azizi, and you'll get a discount on your Bruise Juice with that discount code.
Awesome. Yeah, arnica is one of the few things that I actually do recommend for that kind of thing afterwards. That's great to be able to package that for folks.
So actually what I did was, it's completely clean. I don't know if you know what they've been putting on. They've been using like the arthritis arnica. They've been using other arnica creams that are out there, but that are meant for, different things. So I made it's completely clean, just because I know that skin sensitivity after liposuction, tummy tuck. You spoke on it a little bit with even the silicone tape and how they're having reactions. So your skin is super sensitive, and you don't want to be rubbing alcohols and menthols and all of these other things on your fresh, liposuctioned or tummy tucked body. So I formulated this balm. It's completely clean. It's just arnica. Nothing extra, nothing that shouldn't be on there. It shouldn't cause any type of sensitivities to your skin. And it's just going to help you feel better, heal quicker. And if you put it in the refrigerator, once you start to feel that, hey, Dr. Azizi, before we go, let's talk about this. When their nerves start to wake up, what do you?
Oh, yeah.
I recommend put this arnica in the refrigerator and you just start rubbing it on. When you start feeling that burning, stinging, fire ant feeling, start rubbing, desensitizing those nerves with this cream or even just with your hands. Bringing more blood flow to that area where you're feeling.
Yeah. And I don't know when you tell people to do it. I usually tell people, your skin is totally sensitive that first month after surgery, so I like people to keep it minimal. So yeah. And when when those nerves start to wake up around week 3, week 4, it's just like you said, some people get itching, some people get like burning, and some people just get tingling, but like something cold on there is always, it's a week 3, week 4, that'll be great. And you're right. And definitely you don't want to have any of that alcohol and all the other random stuff. And you're right about the fact that when it comes to supplements and this kind of stuff, that it's not really regulated. So if you're getting something for arthritis or something random, it's just going to be, it's like the Wild West when it comes to supplements.
Right.
So you don't know what you're getting sometimes.
So you don't really know what you're getting. And I made this specifically for post-op care. So there's no extras. It's just supposed to do what it's supposed to do. You can take it to when you're going to your massages, you can have your massage therapist to put it on for you, and helps a lot of that swelling and bruising go away. I've had patients who have tried it and they're sending me progress pictures. And she's like, I forgot to put it on, 2 days ago. And I put it on last night and now my bruises were purple and now they're more yellow. And it's
awesome.
Yes, that's what it's supposed to do. Thank you.
Awesome.
Thank you so much for coming on and giving us
my pleasure.
Such good information. I hope to have you on soon and we can deep dive into some other of the BBL subjects that are too long to go into on the same episode.
Yeah, no, super happy. I hope it helps everybody to kind of get some good learn on. Thanks a lot for having me. I appreciate it. I tend to talk a lot. So
me too.
Hopefully it was me expanding. All right, good. Yeah. Hopefully me expanding a lot of these things help people. But yeah, there's so much more to talk about any of these things. And I'm sure like this podcast will get a ton more questions too, So
yeah, just
happy to be back and do it again.
Send them in. And y'all, let me tell y'all how me and Dr. Azizi got connected. It was actually from our friend Diana, who's the Faja doctor. Mm-hmm. So Dr. Azizi comes with really great recommendations. And, you're the first surgeon that I have on that I haven't met personally. Because I liked and actually you're the first man on my show. I've had nothing but female plastic surgeons that I've known personally that I can vouch for their bedside manner. I can vouch for, their work. And Diana told me, you have to have Dr. Azizi on. He is the GOAT. His bedside manner is, superb. He is really great. So you came with great recommendations. And you guys, if you're even thinking about getting a BBL and you're near Chicago or you're willing to travel to Chicago, you know where to go.
That's awesome. Thanks. Yeah, everyone should feel comfortable. So it's high praise from Diana and try to make everybody feel comfortable. It can be awkward when you're at the surgeon's place, so try to make it as comfortable as possible for yourself.
Right.
You know how it goes. Yeah.
All right,
cool.
You guys, I'll see y'all next week. Thank you, Dr. Azizi.
Thank you.
I would like to end this episode with a huge thank you to all of our listeners. If you enjoyed this podcast, make sure to subscribe to Big Butts No Lies Podcast and follow us on Instagram at Big Butts No Lies Podcast. If you have a topic you want me to cover, please send it to the DMs. If you know anyone on their plastic surgery journey, be sure to recommend them the show. You can also visit us on our website, bigbuttsnolies.com. You'll see the online surgical recovery store. We're adding new items all the time. If there's something you think I need to have on there, send me a DM. Don't forget to leave us a 5-star rating on Apple Podcasts. And don't forget, new episodes every Monday. I'll see you then.